Good afternoon, one and all. It's indeed a pleasure and honor to welcome Dr. Anand Utture here today. He's a senior consultant urologist at SL Raheja Fortis Hospital, Mumbai. His special interests are in endoscopic urology surgeries. So he's indeed a pioneer when it comes to bipolar plasma kinetic resection or technique of prosthetic surgeries in the city of Mumbai. Now, when we think about kidney stones and flexible microscopic, especially bilateral flexible microscopy, the first name that comes to mind is Dr. Anand Utture. So, without further delay, I would like to start the first interaction with him, sir. Sir, uh, for the benefit of the audience, can you just explain what is really the difference between a regular surgery and a minimally invasive surgery in urology today?
Good afternoon, everybody. In urology, the urological organs are kidney, ureter, bladder, and prostate. And all these are situated in the retroperitoneum. Retroperitoneum means the back side of your abdomen. So if you have to reach those organs, you have to take big cuts, big incisions, and reach that particular organ and do the procedures. Instead of that, when we are talking about minimally invasive surgery, these are of again two types. One is laparoscopy or endoscopy, where we make very small cuts onto the abdomen, put some long instrumentation which are attached to a camera, and we do the procedure. In endoscopic urology, what we do is we use a natural passage, and with the natural passage, we reach the stone or a malignancy or a cancer, and we operate upon it. So this is the basic difference between a minimally invasive therapy and an open operation or a regular operation.
Excellent. So, from the patient's perspective, what are really the advantages that this brings on the table from the patient's perspective?
One of the most important thing it does is that it causes less pain. The chances of infection are very less. It's a recovery time which is very, very fast because the incisions are not very big. The scar-related complications are not seen. There is no collection, and it's a very much reduced risk for complication. Apart from that, the surgery which takes place is very, very fast. So the anesthesia time also in these particular operations are very, very less. And that's how it is always beneficial to the patients to do any kind of operation in urology by minimally invasive therapy.
So, can you educate the audience as to which are the various conditions which would be benefited by minimally invasive surgeries?
Almost everything in urology can be benefited by using minimally invasive therapy kind of or operation kind of a thing for the treatment. It is useful in urological cancers, kidney stones, prostates, stricture urethra or narrowing of the urethra, bladder diverticulum, P junction obstruction, etc., where minimally invasive kind of a mechanism can be utilized to do the operations, which will benefit the patients very much.
Sir, what are the different types of minimally invasive surgeries? Is endoscopic and laparoscopic surgery, is it the same?
Laparoscopy is nothing but making a small incision or multiple small incisions on the body and go inside and operate upon the organ that what we want to operate. Here it can be multiple incisions or it can be a single incision just below the umbilicus through which all the instrumentations can be introduced inside the body and you can operate. Second is endoscopic operation where, as the name suggests, it is not a cut onto the body, but we go inside the body using the normal passages. In urology, the normal passage is urethra from where we pass the urine. So through that, we introduce our instrumentation, reach the organ and do whatever surgery that is required.
Okay, sir. So we are seeing really a rise in the number of cancer cases. In your experience, what are the options that are available for the patients today when it comes to kidney cancers, and what are the advantages of them, sir?
Kidney cancers are fairly common. We can operate upon kidney cancers using laparoscopic technique or robotic technique. Now, laparoscopic technique is a technique where the instrumentation is used by the surgeon. Surgeon is directly in contact with the patient. He goes inside, looks at the camera onto the screen and operates upon the internal organs. In robotic surgery, what happens is the robotic arms is directly operating upon the patient, which is controlled by a small cursor which is situated inside the operation theater itself. and the surgeon, the urological surgeon, manages with multiple finger movements all the movements of the robo, and the surgery happens in that particular way. Now, suppose the stone, the cancer itself is less than 4 centimeter. We don't have to take out the whole kidney out. What we do is we do something called as a partial nephrectomy. Now, while doing the partial nephrectomy, you need to understand where exactly the cancer is situated and how the cancer is spread. So from there, we go about 2 centimeters, take an incision onto the kidney, and do something called as a partial nephrectomy. Now, this is a very, very important technique, especially when the patient comes with both the sides of the kidney tumors. Here, we take out the kidney, 2 centimeters, which is normal, away from the kidney tumor, and rest of the remaining kidney can function as a regular kidney for the patients. Now, this is possible because in endoscopic urology, endoscopic and laparoscopic urology, you have very good 3D understanding of uh, the entire organs. All the smaller bleeders which are happening can be controlled very quickly and very fast because all the images are enhanced, which can be seen onto screen and can be operated. This is how the kidney cancers, all the cancers nowadays, are done either by a robotic technique or a laparoscopic technique.
Fantastic, sir. So, the audience would really like to understand what are the different ablation therapies that are available for kidney cancers today, sir?
Very good question asked, Dr. Amit. This is one of the developments which are happening, and these are very much good operative techniques and technology for tumors which are very, very small. In ablation therapy, we utilize two techniques. One is a cryoablation and second is a radioablation. In radioablation, what we do is we enter inside the abdomen, identify the tumor, put the radioablation needles inside the tumor, and we heat this tumor. Now, because of the heat tumor, what happens is the cytoplasm of the cancer cells, they get coagulated, and there is a cell death, the cancer cell death that happens, because of which the kidney cancers can be controlled. Similarly, in cryoablations, we freeze these tumor cells, because of which there is a internal cytoplasmic crystallization that happens. The cell itself, the cancer cell, dies off, and the complete treatment is achieved. And this kind of tumors, we can then very well evaluate on various other modalities like MRIs and CT scan, etc. And if required, these treatment modalities can be repeated again. So patient is living with both his kidneys. It's a minimally invasive therapy, and this kind of treatment can happen, and patient can go home within 24 to 48 hours. So these are the ablation therapies that what we use for kidney tumors.
Sir, I'd like to understand what are the rules about endoscopic surgeries when it comes to ureteric as well as urinary bladder cancers.
Whenever it's a ureteric tumor, what happens is we do not know what kind of a cancer it is. So to identify that, we need to do something called as endoscopic procedure through which we go inside the ureter, identify the tumor, take a biopsy, come out, and then plan our surgeries. Especially in case of bladder tumors, when we are looking at the bladder tumors, most of the bladder tumors, when we come across, 70 to 80% are superficial bladder tumors. That is, the muscle of the urinary bladder is not involved in this kind of tumor invasion. These are the patients who can come down to OPD, can remain in the hospital for 24 hours. Here, we do the biopsy as well as the treatment using either holmium lasers or bipolar plasma kinetic technique, and we resect the entire tumor. In the tumor, after once we resect, we also take a deep muscle biopsy. Here, if the deep muscle biopsy is involved, in that case, the patient requires to be operated and the whole urinary bladder has to be removed. And this can be achieved by doing an laparoscopic or a robotic operation. And this way, even a bladder tumor and a ureteric malignancy can entirely be operated by using a minimally invasive therapy.
So, can you educate us about the options for muscle invasive bladder cancers today?
Muscle invasive bladder cancer, usually what we do is we do a radical cystectomy where urinary bladder as well as seminal vesicles and prostate, everything is removed. The entire procedures can be done with the help of a laparoscopy or a robotic arm. With this, what happens is This usually requires a very long incision onto the body. The recovery time is very prolonged if you do it with a normal operations. So when you are using this minimally invasive therapy, the incisions are very small. You can reach the organ very well. The operation can happen in a very precision manner, and the outcome, because the surgery has happened in such a precise manner, the outcome of the operation is very good. This is how it helps to do an endoscopic management in even deep muscle invasive bladder cancers.
Right, sir. Now, when it comes to prostatic cancer, sir, what is the role really an endoscopic surgery plays in its diagnosis and later on with the treatment?
Prostate cancer is one of the commonest cancers that we see in urology. After the age of 50, it is the second commonest cancer in all the possible cancers in the body. 12% of men will have prostate cancer at some stage in their life. And the 5-year survival in these patients, if it is picked up very quickly and treated very well, is approximately 97%. So, this area, especially the prostate cancer, is the area where laparoscopic and robotic intervention has really helped the patient. In this, very small incisions are taken on the body. You reach the prostate, take out the entire prostate. The suturing of the bladder with the remaining urethra is done using this laparoscopic technique, and the patient can go home within 48 to 72 hours. So this is how the treatment option for prostatic cancer is completely changed by introduction of this laparoscopic as well as robotic minimally invasive therapy.
Fantastic, sir. So, apart from the cancers that we have been discussing, are there any other urological conditions where minimally invasive surgeries has a role to play?
Another common, I would say the commonest problem that what we face, especially in India, is the kidney stone problem. Kidney stone, 1 in 10 men and 1 in 35 women will form stones in their entire life at least once. The recurrence rate, that is, when the kidney stone is formed, the same patient will have kidney stone again, 7% per year. So, approximately 50% of all the patients will form stones in next 5 years. So, whenever we are discussing about any options for these kind of surgeries, the option should be minimally invasive or non-invasive, because these are the patients who require surgery or intervention for these kind of stones again and again. So when we talk about these kind of options, we usually talk about the various modalities that what we have in the form of ESWL, PCNL, ureteroscopy or flexible ureteroscopy. So kidney stone is the area where the endoscopic, that is a minimally invasive surgery, has really helped manage urological patients.
That's it, sir. So, out of the various techniques that you mentioned, how do you decide the modality when it comes to the kidney stones, sir?
Very good question. Now we are talking about the endourological management. Now, in endourological management, initially till about 1980, all the operations on the kidney stones were performed by open operations. In 1983, Chaucer brought about one very dynamic change in management of the stone, and that was ESWL, shockwave lithotripsy. This shockwave lithotripsy used to break the stone which were there in the kidney. So they were of different types: electromagnetic, electrohydraulic, piezoelectric. With this, shockwave is to go inside the body, which were directed onto the stone with the help of sonography or X-ray CM control, and the stone is to get broken off. Over a period of time, we realized that if the stone is very hard, that is when we do a CT scan and it shows that the Hounsfield unit violet is more than 1000 units, these ESWL techniques don't work. In that case, what we do is we do something called as a PCNL. PCNL is making a small opening, about 1 centimeter opening inside the kidney, percutaneous nephrolithotomy. Now, over a period of time, what has happened is this PCNL scopes have become smaller. So you can do something called as a PCNL for large stones. You can do mini PCNL for moderate level stones, 1.5 to 2 centimeters. Then there is micro PCNL. Then there is a needle PCNL. So these are the techniques which are developed over a period of time to take care of kidney stones which are there in the kidney. The best of all these equipments has happened with introduction of something called ureteroscopy. Now this flexible ureteroscopy, we call it as an RIRS, retrograde intrarenal surgery. Retrograde means from down to up. So in this, what we do is we go through the urethra, go inside, go inside the kidney, look at the stone, and then we use a Holmier or thulium lasers to destroy these stones. Now, with this technique, what has happened is, with this technique, any number of stones situated in any kind of kidneys, especially when the patient comes with both the sides of the kidney stones together, this is the technique that what we use to take care of these stones. So stones, whatever is the size, wherever they are situated, and how many are the number, everything can be taken care of by doing this particular procedure, which is called as RIRS. This has really become a game changer, and I believe that this is what is going to be the future treatment for all kidney stones in the coming years.
It was really a fantastic information, sir. Sir, would the options remain the same when it comes to ureteric stones, or is it something different, sir?
Ureter is a small tube where the kidney produces urine. Ureter is a tube through which the urine comes into the bladder. Bladder is the place where the urine is stored and then it comes out when you are passing urine. So this tube which is there, that is called as a ureter. And the commonest presentation of all the stones which we come across is the ureteric stones. Because when the stone gets stuck into the ureter, there is a very, very excruciating pain. And when the excruciating pain happens, this can be second worst pain after delivery pain. So when this stone, when this problem comes up, and the problem comes up with this ureteric stone and the pain, what we do is we do a small scopes, which are called as ureteroscopes, which we introduce inside the ureter. Now, with advent of newer technology, there are something called as pediatric scopes, which are 4 French, which are smaller than even a ball pen and ball pen refill. So these are the kind of stones that what we use and utilize even to operate upon 2 and 3 years old small children and do the entire procedure using the laser, completely destruction of the stone or pulverization of the stone. That's how we take care of the ureteric stones.
So we spoke about kidney stones, we spoke about ureteric stones. What about a bladder calculi, sir? Is it any
Bladder is the
different?
organ where we store urine and then it comes out through the urethra when we are passing urine. This usually happens when a lot of urine remains back in the bladder, especially in the elderly age group where there is a prostatic enlargement. When these kind of stones are formed, initially what we used to do is we used to take a small incision, maybe 6, 7, small is also 7 or 8 centimeter long, in the lower part of the abdomen, go open the bladder and take out the stones. But now what we do is we do an endoscopy again procedure, go through the urethra, or make a small 1 centimeter incision if the stone load is very, very big, which we call as PCCL, percutaneous cystolithotripsy, in which we go inside the urinary bladder from the skin, look at the stone, break the stone, and clear the stone. So this is how we can give a complete stone clearance by doing an endoscopy procedure through the urethra or doing a PCCL for the bladder stones.
Sir, apart from these kidney stones and cancers that we just discussed, are there any other urological conditions, say like prostate enlargement, where minimally invasive treatment has a role to play?
Prostatic enlargement is going to happen to every man. As the age advances, what happens is the prostate enlarges. And when the prostate enlarges, there is urgency, frequency, nocturia. That is, you get up to 3 times at night to pass urine. Your flow of the urine becomes less. And when you're passing urine, the urine comes out in interrupted streams or it falls very close by. These are the problems that what you come across with prostate. Initial management is always the medical and not treatment, but when the initial management with medical and not treatment doesn't happen, then the patient will require surgery. This is one of the commonest problems that we come across. Above the age of 60, 50% of all men will have some kind of a problem as far as prostate enlargement is concerned. And when the age becomes more than 80%, 80 years, more than 90% of all the men are they come with prostate related problems. The surgery that what we do is something called as the TURP, transurethral resection of prostate operation. In transurethral resection of prostate operation, we use the electrical current. Only thing is the prostate has got a lots of blood. So by doing this kind of therapy, there's a possibility of some amount of bleeding. So what answers do we have? We have got newer techniques and technology like HOLEP and THULEP kind of laser technology where the bleeding happens less. One of the best technique which is available is something called as bipolar plasma kinetic resection of the prostate, with which how much ever big is the prostate gland, we can very well subject to that. If the patient is on any kind of heart-related blood thinners like ecosprin or clopidogrel, etc., These are also the patients which can be managed by doing this bipolar plasma kinetic therapy. Then there is transurethral needle ablation, TUMT, that is transurethral microwave thermotherapy, where we heat the prostate gland, destroy the prostatic enlargement, and the patient can pass urine. The newer technique that what we talk about is something called as Euro lift. The Euro lift is a technique where we put clips onto the prostate, clips onto the prostate, and decrease the size of the prostate so that the urethra becomes open and through which we can the patient can pass urine. There is another technique which is developed, which is also available, started becoming available in India, is something called the vapor technology. In vapor technology, what we do is we inject vapors inside the prostate gland. Because the heat energy, the prostate gets destroyed, the urethra becomes open up and the patient can pass urine. So, especially in this prostate operations, which used to be something called the millions or of Freyr's operation, and as a resident, when we were getting trained and we were doing the open operations, we used to always see that so much blood happening as far as this prostate operations are concerned. Now is completely changed over a period of time. Hardly any patient receives any blood transfusion after this minimally invasive latest modality for prostate operations. And this is how it has really helped all the patients.
Very nice, sir. Sir, are there any other urological system organs where minimally invasive surgery has a role to play in its diagnosis or treatment?
This endoscopic management is minimally invasive has come up where we can talk about investigative modalities as well as the surgical modalities. In investigative modalities, if there is a problem in, say, the patient is having bleeding and you want to find out where the bleeding is coming from, we can do a cystoscopy. We can do a ureteroscopy looking at the ureter. We can do a flexible ureteroscopy, go inside the kidney and look at inside. So that the smallest of possible tumors which are there, they can be taken care of. Another thing, minimal invasive therapy, which has really helped is doing a prostatic biopsy. Now, this prostatic biopsy, initially what is to do is to cut the prostate, take out a small chip, and send it across for evaluation. But now, over a period of time, what we do is there are special guns with which we go from the rectum, look at the prostate gland, looking at the sonography, and take about 18 to 20 prostatic tissue chips, which are sent for evaluation so that we come to know that whether the patient is suffering from prostate cancer. Now, why these investigations have become so much so forefront is because the prostate has become, as I've said already, second most commonest cancer in the body. This is how it is helping to even evaluate by doing this minimally invasive or minimally or non-invasive technique to identify problems in the urological patients. Along with that, all the organs, starting from suprarenal or adrenal gland, the adrenal gland resection or a removal can be done by doing an laparoscopic or robotic operation. Second is pyeloplasty. Small children come with urine which doesn't flow from kidney into the ureter because the narrow space which has happened in there. In that particular area, you can do a laparoscopic or robotic operation and join the pelvis to the ureter so that the patient can pass urine and without having a big cuts onto the body. Many of these patients come with bilateral problem. That is, both the side of the kidney can have this kind of damage where the Pew junction valve is there, where in one operation on both the sides, everything can be operated by giving very small incisions on the body. Then, if there is an injury which happens in any of the gynecological operations, we can do an endourological procedures, try to stent the ureter, or if required, we can do a laparoscopic procedure, cut the ureter and put it back into the bladder, which you call as a re-implantation of the ureter. Many times, small children come with something called as VU reflux. In this VU reflux, we do an endoscopic procedure, inject specialized chemicals at this junction because of which the urine flows only in front, doesn't go back into the kidney. Along with that, many patients who have got urgency frequency, especially females, who are suffering from neurogenic bladder or interstitial cystitis. These are the patients, many times we do an endoscopic procedure and we inject Botox injection therapy inside the bladder, because of which the minimally invasive therapy can take care of urgency and frequency which is happening along with this bladder symptom, so that they don't have to pass again and again urine, and it can be taken care of. Another thing that we come across is if it's a sexually transmitted disease, or if there is an injury which happens to the urethra, the patient can come with something called a stricture urethra. Now, in stricture urethra, we have to take long incisions inside the perineum, that is in between the two legs. Go inside, suture this, cut the suture which is a damaged portion, and suture it back. Or take a small portion of the inner aspect of your mouth, or take a tube and attach it to these two parts that what we have cut of the urethra. When you are doing a minimally invasive therapy, you can do an endoscopic operation, go inside, look at this whatever sector which is called, make required cuts either with cold knife or do with lasers, open this entire urethra. And these are the patients who can get operated in the morning and go back home in the evening. So this is how endourology has helped to manage almost every aspect of urological problems.
It was really a valuable information you said, sir. Considering your years and years of experience, can you tell the audience what they can expect in the future, or what the future holds for us?
The way I look at the future, it is going to look at as all the urological procedures in urology will happen and almost have happened with this minimally invasive therapy. Few more developments can happen in the form of the endoscopes can be smaller, the lasers can be of higher power, where the destruction of the stone or pulverization of stone can be faster. With the advancement in optics and 3D vision, the entire organ can be looked onto the screen in a better fashion, where a surgeon can have a good, nice dexterity, so that the entire tumor or a stone problem or any other urological problems can be tackled very, very simply. And AI, that's what people are talking about as far as the development is concerned, which is come in a very big way in medical field. With this AI technology and AI technique, all the instrumentation, the finer movements, etc., can be taken care of, and the various stimulators can be manufactured, where the junior doctors who are getting trained by doing surgeries again and again can be in the initial period be treated or be trained onto these stimulators and can directly come into practice. And that's how an expert person who is not even operating upon the patient but knows how to operate upon this patient by working onto these stimulators with the help of this AI can operate upon this patient and give better results.
Fantastic, sir. This was really a valuable information that you shared, and I'm sure it's going to help the audience in a long way to understand the challenges that lie ahead and the future, the hope that lies in the future. So, with that, I would like to really thank Utture sir for taking his time out and sharing his valuable knowledge with the audience. Thank you.
My pleasure, Dr. Amit. Thank you.